Hello, my name is Saif Al-Amiri, and during this presentation, I will introduce the disorder known as somatic symptom disorder, which I will refer to as SSD throughout the presentation. I will provide you with the definitions of the SSD, show you the DSM-5 checklist for diagnosis, define the two identified pattern along with brief an overview of belief causes represented by the psychodynamic view and behavioral view. As defined in our text, SSD is a disorder in which people become excessively distressed, concerned, and anxious about bodily symptoms that they are experiencing, and their life is are greatly and disproportionately disrupted by the symptoms.
There are two identified patterns of SSD. Somatization disorder is one identified pattern of SSD. In this pattern, individual will suffer from numerous symptoms in varying location and intensity. The ailments often present with this pattern are pain symptoms, such as headache or chest pain, gastrointestinal symptoms like nausea or diarrhea, sexual symptoms like erectile or ministerial difficulties, and neurological type symptoms such as double vision or paralysis. Individuals suffer from these patterns, go from doctor to doctor looking for some kind of relief, and are often overly dramatic about their symptoms. These can last for years, fluctuating in severity but never truly goes away without therapy. The other identified pattern is predominant pain pattern. In this pattern, the individual primarily symptoms is the experience of bodily pain. The source of the pain may or may not be identified, but the concern and disruptions produced by their pain are disproportional to the severity and the seriousness of the pain. This is the most common pattern of the SSD. It can develop at any age and it presents more in female than in the males. This pattern is likely to develop after an individual suffers from an accident or illness that cause genuine pain, which that then takes on life on its own. SSD was originally referred to as historical disorder due to the prevailing belief that the bodily symptoms were caused by excessive and uncontrolled emotions. However, in the late 19th century, researcher Amboise Auguste Lilipo and Hippolyte Verheim presented the idea that psychological factors may be behind this disorder. They found the Nancy School in Paris to study psychological disorder and their treatment. While studying hypnosis, they discovered that hypnotic suggestion could both produce and reverse physical dysfunction. This discovery leads them to believe that psychological processes were definitive cause of the hysterical disorder. Sigmund Freud's creation of psychoanalysis actually began when he wanted to explain the hysterical symptoms of his patients. After helping Joseph Breuers successfully treat a patient suffering from hysterical deafness, disorganized speech, and paralysis with hypnosis. Freud developed the belief that the symptoms were actually a conversion of a patient's underlying emotional conflict into physical symptoms and concern. After observing the majority of his patients suffering from this disorder were women, Freud developed the theory that centers on the needs of the girls during the phallic stage, ages 2 to 3, 2 to 5, where Freud believed that girls develop the elected complex, a pattern of desires where all the girls develop sexual feeling for her father and rivalry feeling toward her mother. Freud theory state if parents overreact to the girl's sexual feeling, the electric conflict will remain unresolved. This then leads to life full of sexual anxiety for the girl, who will develop the unconscious needs to hide anytime she begins to feel sexual feeling. Today, psychodynamic theorists build on a Freud theory, dropping the heavy focus on sexual feeling. They apply the theory to any unconscious conflict carried from childhood that cause anxiety that can be converted into more tolerable physical symptoms. They they have proposed two mechanisms that are work with the SSD. One mechanism is for primary gain. With this mechanism, individuals who suffer from physical symptoms derive primary gain when their symptoms keep their internal conflicts of awareness. Mechanism 2 is for secondary gain. With this mechanism, individuals derive secondary gain when their symptoms allow them to avoid unpleasant situation or receive sympathy from others. Behavioral theorists believe that the physical symptoms of SSD bring rewards to the individual suffering from them. Therefore, the individual learns to display the symptoms more in order to receive more of the rewards. Studies shows that the individuals who are diagnosed with SSD develop physical symptoms after their close family or friends were diagnosed with a similar medical problem. The behavioral view is similar to the psychodynamics notion of secondary gain. The difference being that psychodynamic theorists view gains as a result of the conflict that caused the disorder, while behavioral theorists see the rewards as the primary cause of the disorder. Both psychodynamics and behavioralist views of the cause of the SSD have received a little research support and minimal clinical case support. This is mainly due to the fact that in most cases of SSD, the pain and upset created by the physical symptoms of the disorder far outweigh any of the rewards gained.